Welcome. We are going to go ahead and get started. Thank you for joining our webinar on GE Centricity, how to cure hiccups and create a seamless patient experience. If you have any questions regarding the content we're showing, please feel free to submit your questions using the chat feature. If we're able, we'll try to answer questions during the presentation. If not, we'll cover them at the end of the presentation. We'd like to start by introducing ourselves. My name is Krista Bennett. I've been with Ortho Northeast for 16 years. I've been with DataDrivers for 4 years. I'm the manager of clinical operations. I oversee the day-to-day operations here at Ortho Northeast of the clinical department, which includes 60 staff members.
And Ms. Tom Pollock. I've been with Orthopedics Northeast for 12 years and also been with DataDrivers for about 4 years. I'm the clinical informatics engineer here at Orthopedics Northeast, which simply means I'm the EMR liaison between the clinical department and the IT staff. So do the communicating in between there. So go ahead. DataDrivers was founded in 2013. Excuse me. We are a wholly subsidiary to Orthopedics Northeast, also known as O&E in Fort Wayne, Indiana. O&E is a 54-year-old company that has been on Centricity since 2002, and MR since 2006. O is like many practices at the launch of their EHR. We struggled. Our staff and providers were unhappy and knew they needed something. So we went and visited other practices and learned from them, and hope that we can help you with some tips and tricks and things today. As we progressed through we began to realize that there was data that we could use as a competitive weapon. So we're going to go ahead and get started. That's the next slide. So our objectives today, we want to learn about some tips that you can help make your staff successful, and some tricks that actually maximize that patient care and increase that efficiency in the clinical department. And hopefully discover, how to use behind-the-scenes tools to make Centricity do the work for us. Again, Orthopedics Northeast, we started in 1962. We've got 14 locations in Northeast Indiana. 6 providers, 28 physicians, 7 anesthesiologists, and about 30 advanced practitioners, which would include nurse practitioners and PAs and CRNAs as well.
Some of the obstacles that we were experiencing, scheduling was a nightmare. We had over 50 providers at that time, hundreds of individual preferences. I don't know if any of you are in the same boat that we were, but we had the big binders, and we had several binders throughout the organization with physician scheduling preferences, and they weren't all updated at the same time, so they all had different preferences. We figured out how we help staff remember everything. We try to figure out how we can keep the physicians happy, how we can keep patients happy with these kinds of preferences, and help keep staff successful at their positions. So in scheduling, we take about 450 average calls taken per day. Approximately 125 of those are new patient appointments scheduled per day, and we have about 4 to 5 appointment schedulers taking those phone calls. What we decided to do, we created a scheduling triage form. So we took all of these preferences, kind of threw them into an Excel spreadsheet. So got rid of our binders, we kind of created them in an electronic format. And we created these rules within a form. So the staff would start answering questions, and it would create pop-up verbiage. So the staff would be able to script certain things to the patients as they're answering questions. Things that read were required, so the staff couldn't move on until they had asked patients certain things. It also prompts them in pop-up verbiage, so you can see on the bottom left there, the staff would read the same verbiage to patients, so they don't have to think about the words that they're saying to patients, and they're saying the same thing to patients so that it's consistent. Certain letters are prompted to be sent out, whether it's by email, depending on the reference, so that it's automatically generated so the staff don't forget to do that once they're off the phone call. Sets expectations for patients. It is easy for the staff. It cuts the training time down. And again, it helps staff be successful, so instead of sifting through binders and feeling like they weren't able to do their job or getting yelled by their supervisor or by their physicians, it made their job much, much easier. The patients having a scheduled appointment and they arrive at the office, then we want to gather their health history information. So we do this a little bit differently. We actually have the front desk staff start to gather their health history, which is much different than most practices. It's just the subjective information, so they're not making medical decisions at this point. So you may wonder why we use non-medical staff to enter this information. So what we're trying to do is we're trying to increase efficiency, and things that take a lot of time to do, we're trying to keep out of the clinical exam rooms in the back so that those exam rooms can keep their flow. We want to keep the physical or the clinical exam rooms filled with patients so that the physician flow can be continuous. We want to keep the patients engaged. So instead of sitting in the lobby waiting, they can be going through the registration process, having their health history updated, and we want to use the clinical staff to work at the top of their license. So the desk staff can capture this subjective information. This will help keep the physicians happy because the time is not wasted in the exam room where the medical assistant or the nurse is spent trying to figure out what that little green pill is that the elderly patient takes at night. So one of the ways that we help expedite this process is we have this piece of paper. It's a laminated form that we have at the front desk. We use sit-down registration. So this is at each one of the registration desks. We also have this in the exam room. So if we, the times that we update the entire health history once a year with patients, then we can do it easily in the back as well. So you can see at the top the allergy, are you allergic to any of the following? We give the staff the scripting to say so that they don't have to think of the words at the top of their head, and again, so that the staff are saying the exact same questions, misinterpreted. We can hand this over to the patients and tell them, can you take a look at the blue section? Are you allergic to any of the following? And then the patients can take a look at it. As you can see, the section in red for patient history is very lengthy, and it's much quicker for the patient to look over that list than it is for the registrar to list all of those, to read all of those, plus they would need about 4 bottles of water to go through those. So again, it just helps expedite the process, speed the process, and then it helps us be more efficient in the back. So as we're going through, as the patient has that laminate in front of them, this is just an example. We're going to go through the tabs that we have for our health history information. This is kind of an example of the medication form. Physician history. So as you can see, we're just following along as the patient is following along on that laminate form. I'll make it easy. The top left, that all negative unless otherwise specified, we can click that button and it prompts all the fields to be no, and then we can go back through and add the yeses, or we can do that the opposite way. We can add the couple of fields that might be yeses and then click the all negative, and it will fill in all the fields we have not answered to no's. So we want to make it quick and easy for the staff. For orthopedic, we care especially about the orthopedic surgical history that they have. So we have the most common surgical histories here, but then also on the bottom right, a lot of patients don't know exactly what surgeries they've had, so we do allow them to let know any generic surgeries that they have as well. Social history, this is where we like to embed a lot of our required questions. Again, you can see in red, pneumonia vaccine, flu shots, tobacco use, falls. This is where we capture a lot of the PRS measures and a lot of the MIPS questions. Any Tom that you want to add on this one? So I'm going to go into the clinical overview a little bit about how our workflow works once the patient gets to the back office. Each physician team consists of 2 clinical staff members. Most physician teams have 4 rooms that they see patients out of. We have 1 to 2 CAS techs for each office, and they function seeing patients for the entire office. So if patients CAS, we take patients to the CAS room for that. We have a person of attachment, which is kind of an odd term, I know, but that could be a medical assistant, athletic trainer, or a nurse, and that is a person that is attached to the physician that follows the physician from office to office. We have a roomer, which is typically a medical assistant, and that is a staff member that rooms the patient and starts the interview process. And then sometimes the advanced practitioner will see patients alongside the physician, or sometimes they will have a separate schedule at another office. So the roomer or medical assistant will call the patient from the lobby, start interviewing the patient. This is where we are the safety net for the front desk, because the front desk is not medical. We're safety net. So we're briefly looking over the information, the H&P that they have entered. If the patient has a negative health history, but they have 5 medications, it's the medical assistant's job to put that together to understand what they're taking their medications for. So again, the front desk has done us a huge favor by taking up the time to go over the health history and enter that information, but it's our job to make sure that everything is accurate and the story is put together appropriately. So they also start to gather the information of what they're being seen for today and go off the physician's protocol of what needs to happen next. The provider will see the patient next, and then when the provider comes out of the exam room, they typically hand over the orders to the person of attachment. That person of attachment will then enter most of the orders, whether that's a work slip, physical therapy, medications, test orders, surgery orders, anything of that nature. The way the providers function, we kind of allow, or we kind of make our forms so that it allows the physician teams to function in different ways, because of course, just like the scheduling preferences, they want to function in many different ways. So some of them will type, some of them will use the forms, and some of them will use scribes. This allows the physician teams to see between 35 to 60 patients per day. This is what our form looks like. You can see the 3 tabs at the top, and that just goes along with the workflow that I just described for you. The HPN review tab is what the roomer would initially start with. A lot of the information is blocked because we want to guide the users to do the right thing. Red is required. You can see, is this a nursing home patient? This is most likely a Medicare patient, and what we're trying to figure out is this a patient that possibly is in a SNF? And if we answer yes to this question, it's going to send an auto flag to somebody in another department to alert them that it might be a SNF patient. So out of the hundreds of patients we see in a day, they're going to get a flag just from a handful that they can look into to know that it's possibly a SNF patient, which makes their job much, much easier from those out, from a needle in a haystack. So it's prompting me that I haven't entered if the physician or supervising physician who's the provider for today's visit. It's telling me that it's time to update the social history, and it's also prompting me again for patient's insurance that I need to answer the skilled nursing facility question. You can also see on the top right, different buttons of different colors mean certain things. The aberrant behavior forms there, I'm going to show you in just a moment. That is dynamic. It shows up for different providers, but some providers will not be able to see it based on their specialty. The hair screening form, you can see the date. It tells us the date that it was last updated, and we change the color based on what needs to be done. So if it needs to be done today, there would be a stopper there in that big gray section, but it would also be bright red to bring attention to the user to tell them that it's time to be updated. Once everything has been cleared out, meaning we've taken care of those 3 stoppers, then everything is going to upload on the form so that the user can move on. So we want to make the forms do the work for us. We want to work smarter, not harder, and block the users from moving on. Okay, so here's the example of the aberrant behavior form that I was showing you before. So this allows you to view everything all in one screen. So these aren't things that we would necessarily have on patient's office visit. But this is, we also have pain management. So these are all of the patient's quote, bad behaviors all in one document. So we can look at the patient's story all together in one view. Makes it easy for staff to document, and then we also use this to pull together on a dashboard later when staff are prepping for these patients to come into the office.
Here you can see some different triggers to help your staff to do the right thing and identify things. So first one example is what Krista was talking about with the aberrant behaviors. It typically is green, but there's a behavior that has been documented. It changes it to red, as you can see above. So changing colors of buttons can help staff identify that there's something different going on. Adding text like the no previous UDS found, or the fact that there's a historical display showing that the narcotics contract or whatever you want to show a date and what doctor it was written under. The pharmacies, again, historical information that you've already documented. Now it's in a form in front of the staff so they can see it at the right time they need to make a decision. The dynamic reveal having to do with that whole thing Krista previously mentioned, the narcotics contract and or the pharmacy and the print, that whole second 2 rows, potentially the aberrant behavior form would not be even seen if it was a different surgeon who's not interested in that kind of information. So you can dynamically show things for different doctors and show other things for other doctors. Kristen mentioned red is required. So required, you can add some required fields. You know, if you're having pain, what kind of pain medicine on you? When did you take it last? Who is your previous doctor? Kind of functional goals. That button is in red because we want our staff to understand it's required because doctors need that information to be able to proceed. And this is a video of our injection form, so we'll go ahead and play that. As you can see, the provider there, we pick a diagnosis for the patient, pick a large injection, we pick a body part, it happens to be a knee, pre-populates that line with the, excuse me, how much of that is needed, how much marcaine, lidocaine. We can add text and bill, creating all that text that we talked about, alternative treatments, as well as benefits, risk, complications, things like that. And then talks about how we give the sterile injection. We have some other information on the bottom. The patient has, we want to inform them of more information because this is going to go on their visit summary when they're done and they leave our office today. As you can see from clicking that one button of add text and bill, I billed for the 2 cc's of that Kenalog, converted it to units as well, and I've charged for a large injection. This video talks about injection. So you can we diagnose the patient, and we're going to pick the body part. In the series, this is going to be the first time we can track the lot numbers, the injection injectable that we're putting in there, expiration dates. There's a pop-up here that tells you warns the staff that if they're not allergic, to keep going, but if they are allergic, you need to use something different, like an orthovisc. And there's pop-ups there as well that are kind of stopping the staff. Now you can see we put in that orthovisc, and now it allows us to print the ABN to allow get the patient to sign. Adding the text and bill, similar things as the form before. We can talk about the potential risks and complications and doing injection under sterile condition and that kind of thing. There's the rules, override rules, if you get medicines in prepaid and/or samples, the document. Again, I've done the large injection with the injectable and the billing. This is talking about a pre-approval process, so you can actually help the staff to send this to any pre-cert staff that you may need. If you sue parts, well, you can't do that based on that insurance rule, so we're going to do orthovisc for that right knee. And then we can go ahead and send that to our pre-cert department to make sure that they pre-cert that medicine. Yes, but also sends an auto flag to that pre-cert department, notifying them that, hey, we've got one that needs to be pre-approved prior to next time that they want to come in and see the doctor. And I believe there's another video we're going to show you. This is our super bill form showing you the modifiers because we did that injection. Some modifiers, just diagnosing the patient. The doses were entered. If there's a global period, it tells you if it's expired in this case. There's some notes up there at the top that come right from the appointment scheduling. So if the consult, you can see it came from a doctor's office. The information button, the question mark on the side that we're looking there, basically it's an informational video that we did in YouTube to try to help the patient or the staff remember how to do certain things. So in those videos in there. So those are the orders that we put in for this patient. I think that's it on that slide. These are examples of different pop-ups and different alerts. You know, if an H&P has to be updated, that's going to come up, and everyone's going to see that when that chart is open. If it's Medicaid, if they require certain things, pre-cert needs to be obtained before we give different services. So examples of pop-up alerts that you can embed into the system. Actual physician tab. You can see from the physician tab, there's different colored buttons up top. Those are your PE forms for all the different body parts. Our physicians are typically responsible for their physical exam, their imaging studies, and to diagnose the patient and to get that impression started. And then they tend to delegate the plan, but they can do it on their own as well. And every team actually operates differently on how much they do. So just showing this all on one page so our physicians can focus on that one page and be able to access all the different PEs, imaging studies, and diagnosis forms. This example of one of the PEs, this is for the knee. You can see in blue is at the top are normals. So you say that the normal right knee. You could say the left is right, same as the right, or you can say the left knee is normal without even actually going to that radio button at the top. Underneath those are what we call easy buttons. So if you have a medial meniscal tear, click that. It'll fill out and fill all the drop downs and radio buttons and text fields on what we think a normal medial meniscus tear would be. Now, having said that, they can always go in and make changes, make adjustments, do additional tests, things like that on there as well. This example of a previous button, so if before you actually get to that knee PE we just showed you, you can actually read what the previous PE was. So if there is information on there and nothing has changed, you could actually say, yes, I want to bring that forward, and then you can edit it if you wanted to make a quick change without actually having to go to the form. But just a yes or no pop-up that the providers can address last visit to this visit, or just see what they put down for the last visit.
Something that helps the physicians, again, for efficiency, instead of going through the Documents tab to look at their last note, this helps them look back at their last visit to how the patient's exam was.
So a few tips and tricks. We try to make sure that your color schemes are the same no matter what form that you're on, whether you're on a PE form or a main form or whatever that looks like. So buttons are typically associated with recheck visits. So this is the tips and tricks that we would give our staff when they would start to understand that what some of these things mean. Fracture care buttons are always the same color, that greenish color. If we're going to print something off, it's typically always yellow with some kind of black text. Our help buttons or protocol buttons are in a dark gray with black text. And you see a lighter gray with a blue text that's underlined. That signifies to the staff that there's a hyperlink, so it could potentially open a file that's in a shared file that they can see, whether it be a protocol or a PDF file of some other information. In this case, it's just the Celebex rules based on our different doctors and what they would like to see. That blue question mark, we just went over that one. And then adding our buttons are typically in red. So if we're going to add text, we're going to add text and bill. We're going to add text and bill and send a flag. Whatever it looks like, it's typically in a red button. So just something to think about when you're creating or designing your forms, that try to make some consistency so those colors mean something or mean the same thing to everyone. In summary, hopefully the cost saving, reducing training time. The EMR does the work for you. That's always your goal. Try to see more patients. We experienced a decoupling where our doctors in their mid-levels started seeing patients about a year and a half ago separately, which required us to be able to be more efficient in the clinical department because we didn't get a lot more staff, if any, added to be able to manage almost a third to a half more patients that they would see on a given day in the same office. Always make it easy for your staff and physicians whenever you can. Simple ways to keep things out of their way that they don't need. Make it easy for them to logically go to the next thought that they would have. They should be able to go to that next step of your forms in the process. Increase your patient throughput and patient satisfaction. A number of comments from our patients about how efficient we are and how well we do, and making sure. I'll give you a great example. We used to ask the same question. Please, let's talk about your medications. Well, now we can see through our forms that the previous person has asked about those medications. So you pose the question, I see that you're on medication X and medication Y. Let's talk about those a little bit more if you need more detail. So just clicking on the interview from the person in front of you helps patients to think or understand that you're actually talking to each other, that your staff does talk to each other. And just overall, maximize centricity. It's an extremely powerful tool. Our CEO says we used to have this Lear jet sitting on the runway. Now we've learned to how to get that plane in the air, and we fly loops all over the place and things like that. So minimize centricity and what it can potentially do for you. This is a great time for questions. If you have any questions, I think our moderator might have a few questions. So we have one question about the injection form you showed, pre-populated protocols. The question is, how do you change those? How can they be changed? Krista, I'll let you answer that question.
the injection video that Tom showed, the protocol was populated by the provider at the top, so I believe that one was Dr. Gimlick. That was Dr. Gimlick's protocol. If he decides he wants to use a different type of cortisone, you can change that in the drop-down. So each provider has their own protocol that's programmed in, but it can be changed. You can change for any, you can change the cortisone, you can change the amount, you can change anything that you want to per patient. You know, for most of our physicians, if they're doing a knee injection, it's the same knee injection. But if, for example, if it's a diabetic patient, they might use less cortisone or less steroid on that patient, so you can just change it with the top of a button.
On the fly. Good.
Yep.
Another question here. It says, how to determine those PE easy buttons that you talked about? How do you determine the criteria? Well, actually, the way we did that, we started off with a committee of a group together. So we did it by specialty. So all the physicians that saw knees, for example, they got together and agreed what a normal medial meniscal tear would look like, or what a normal, the other easy button. So they would do that. More recently, we've become more specific in the fact that you can make those easy buttons specific to each doctor. So Dr. X, his medial meniscus tear could look different from a typical medial meniscal tear for Dr. Y. So those can actually be doctor specific as well.
Okay, another question here. It says, since you have designated roles for staff, what happens if someone calls in? Since it looks like you had specific members of each doctor.
So POAs are assigned to physicians. So if those physicians are in office, they're working with that specific physician. The roomers are assigned to a certain set of rooms. So Sally might be assigned to rooms 1 through 4 at a certain office. If it's not a physician in those set of rooms, then she might rotate to another set of rooms. If one calls in, then I just take from the pool of maybe there's a physician that's in surgery, or there's a roomer that there's not a physician in those set of rooms. So most of the staff are cross-trained, so most roomers can function in a POA role, and most POAs can function in a roomer role. I think the EMR makes it easy for them to do that because the training time is small, so they can pop in each other's role.
Okay. Well, it doesn't look like we have any more questions. Oh, wait a minute.
Coming in. Is that 4 months into using GE in a multi-specialty practice, include therapies utilizing Therapy 1 forms, and we're dealing with a transition from 5 legacy systems to 1. But when you say you have really taken off, how long would you say it took you to get to that point?
That's a question. I think we started in EMR forms in 2006.
Considering we did it all wrong the first time.
Yeah. I think that might be the trick, is we're hopefully helping others to not do it wrong the first time. We created our forms in 2010. It took probably a couple of years to make those pretty good. But to be honest with you, saying around here, if you don't like change, you're in the wrong place. So we're always trying to make our forms do more things and help our staff get better, more efficient. And at first, it's always a group of people that are the champions that are trying to start things off and creating forms and analyzing workflows and things like that. But the more you get, the more you can open it to your staff for ideas. We have an ideas page they offer to our different staff, and they get a picture of their picture put on there with their idea and things like that. So the more you can open it up to them and they take ownership of it, the more you can continually change it and make it better. But you got to get to the grassroots staff to understand one thing may or may not be working. But it's not something you're going to do overnight. but it's something where you continually get better and better, and you find more ideas, and you progress more from there. Kristen, else you'd like to add?
Yeah, another thing that we do when we implement something new, whether it's a new workflow or something like that, we tend to do it towards the end of the morning or the end of the afternoon. So if it completely bombs, we don't back everything up. You know, if we do it first thing in the morning and it backfires on us, we don't want to back all the patients up and have a domino effect from the rest of the morning. So if we change our workflow or do something different, we might choose to do like the last couple patients of the morning. So then at least after those patients, we have a break into lunch to think about it and rework and maybe come back the next day after, you know, we made some changes. Or if it went well, maybe we'll try the last 4 patients of the afternoon or something like that. So that's something that we've always done, and if it works well, then the next day maybe we'll try the last half of the morning, and we just kind of baby step in it in that manner. So Tom's exactly right. We're always changing things. We're always trying to make things better, and from staff recommendations, they're the ones that are in the trenches and the ones that say, you know, if you can make, this is something that I do 20 times a day, is there a way to make it easier? And we try to take those recommendations to heart, because they're the ones that, if they see you trying to put their suggestions into action, then they know that you care about them as well and trying to make their job easier.
Another question about what information is typically entered by the physician and or the mid-level provider. Well, it depends on your team. If the team is the mid-level, if the mid-level is going to work up a patient for a physician, then they could potentially work up the whole entire visit, and the physician just kind of walk in and put his final impression on and develop a plan. But if you see a patient separately, I would say actually our providers, whether it's a physician or a mid-level provider, is responsible for their physical exam, their imaging studies, any kind of imaging study results they see, and their impression, and they typically then delegate the plan. We have developed a quick sheet where they can actually just circle some answers like I want an MRI next visit of the right knee, we're going to do an injection next visit, that kind of stuff like that, just to help out that POA. That way the provider actually gets into the next patient's room while we're wrapping that one up. Anything else you'd like to add?
I don't think so. That's pretty clear. As far as them entering the impression, a lot of times the provider will tell clinical staff what the diagnosis is, and the clinical staff will actually enter the diagnosis. ICD-10 form, and so we'll actually enter that and put that into the office note. They're telling us what the diagnosis is, but we've also we used to use our advanced practitioners as an expensive scribe, really, until we decoupled them. And so some of the physicians have chosen to use a scribe, excuse me, so that when they come out of the exam room, you know, the scribe goes into the exam room with them, and when they come out of the exam room, they're much done with their documentation. And they found that by doing that, they can see 3 or 4 more patients in a half day. To them, it's a valuable resource, so all they have to do is review and sign their notes off. So each physician is a little bit different. We find that the older physicians tend to use a scribe. The younger physicians, you know, them go through schools, they're using the computers, they're doing everything in the computers when at school anyway, so they're more apt to do computer.
One of the viewers said, wants to know what the skill set of our forms developers. Well, we do actually have a couple of them, but their education is just computer science. A little bit of programming through there, but they're not actually, that's not their major. They are just computer science majors. The younger they seem to pick up language very quickly. well as all the other things, the new HTML stuff that is being developed and things like that as well.
Have you done something like this specific to Therapy 1 forms, or is there one planned? We have not, but I will take that back to the team, and I think that's something that we very much consider. Yes. Take us back to the scheduling call center script and how that ties in. Absolutely. Allison, can you go back to 1, 3, 4, 5? That'd be like slide number 8, probably 1, 2, 3, 4. Maybe slide number 7. I think she's talking about
after this.
Before. About the triage form.
Mm-hmm.
Very big.
Where we put in the consult information?
Like there. I believe this is what she's talking about. If not, then please say a big fat no. I believe this is what you're talking about. So this is where, we brought this in because this is where actually we call it the circle of life. This is where the patient visit really starts when they call in to schedule their appointment. And what was happening in our world where the patients were not getting on the right physician schedule. So we would have patients that would, doctors that didn't really want to see feet or didn't, that wanted to see blue light only Friday would be seeing them on Tuesdays. And so this ensures that the right doctors were seeing the right patients. Some of our total joint doctors only see patients over 40, and some of them see pediatrics, and some of them see toenail problems, and some of them don't. And so this form alone is very complicated and could be a webinar actually in itself. We've done presentations on it alone because right in the middle of that form where you see the doctors and advanced practitioners, the list of doctors changes based on how you answer the questions. And it's based on insurance, it's based on body part, it's based on whether they've had surgery or if it's a second opinion, if they've had an injury, if the knee goes below the knee, or, it's pretty complicated, but that's based on physician preferences. So if that's something you're interested in, let us know. We can do a free webinar with you and your practice on that as well.
Any other questions?
There was one about an office note. Was there one?
I've gotten to all the questions, unless anybody else has any. If we didn't get to your question, we will read it and actually email you offline with that. Just one little side note, Orthopedics Northeast through DataDrivers, or vice versa, DataDrivers through Orthopedics Northeast does do site visits. We typically bring one practice at a time, and those usually are scheduled once a month. So if you're interested in something like that, love to have you come in and kind of see how these forms work in real life as they're being used on a day-to-day basis. One of the things different from DataDrivers, Orthopedics Northeast, is the fact that we use everything in daily practice. So, questions good? All right. Well, thank you very much for joining us today, and we hope you all have a great day. And until next time.
Yep. Have a good one.